This is going to be a monthly webinar series that we're going to do. And as we get new topics that come out, you will be notified via email. All right, so a little bit about Dr. Harris Jackson. She is the Director of Research and part owner of Omega Quant Analytics, LLC, and is the Assistant Professor in the Department of Internal Medicine at the University of South Dakota Sanford School of Medicine. She received her PhD in Nutritional Science from Penn State University in 2013 and completed her training to become a registered dietitian in 2014. She continues her research in the area of omega-3 and maternal health, helping create the prenatal DHA test and the mother's milk DHA test, and continues her clinical research and work by consulting with clients on their lab values from Omega Quant. Dr. Harris Jackson, I'm going to turn it over to you, and looking forward to the presentation.
Thank you, Tavis. Let me share my screen. Tavis, everything look good?
Looks great.
Okay. Thank you all so much for coming. We're talking about omega-3s and vitamin D and immunity today. We're just doing it in two chunks, vitamin D first and then omega-3s. And the learning objectives are to understand the role of vitamin D and omega-3s in immunity, how blood levels affect and are connected to immunity, and then how to incorporate them into the diet and supplementation through some clinical examples. So let's start off with the immune system. What is it? The immune system is, we are continually exposed to organisms through inhaling, swallowing. Our skin and mucous membranes are constantly being exposed. And whether or not we get sick from being exposed from all to these organisms is dependent on how pathogenic the organism is and how the integrity of the host defense mechanisms, how good are the host defense mechanisms. So it's very, very broad and includes so many different aspects. So when we really think about the immune system, it's usually easier to understand it looking at when things don't go correctly. So when the immune system is overactive, we can get, or underactive, then the organisms from the outside can cause severe infection. There's also tumors of immunodeficiency, but the immune system was not able to hold off the attack. The immune system can also be overactive, and in that case, the immune system reacts to organisms that are not pathogenic, and you get allergies and autoimmune diseases. So having a nicely balanced immune system is really key for overall health. The immune system is made, not born, and we know this through even just the discovery that breast milk contains cells from the immune system to just start building up babies' ability to fend off those pathogenic organisms. And the immune system, you see, it's very complicated, but in general, we can think about acquired and innate immunity. And the acquired immunity is what remembers what we've been exposed to in a lot of ways. It also helps identify the viruses that have been infected, or the cells that have been infected by a virus, so that other parts of the immune system, usually the innate part, can come and clear away all of those infected cells to quarantine them so they can't infect the whole body. The innate system is kind of where inflammation really comes into play. If the organism makes it into the body, then we have our white blood cells and all of these different cells that help to try to neutralize the virus or the bacteria. And they're communicating back and forth between the acquired and innate sides of the immune system. And then we have the biggest picture is the physical barriers, where we just, our skin and our saliva and stomach acid, anything that would be kind of exposed to the outer systems is a big part of keeping us safe from excess pathogenic organisms. So during COVID, a lot of interest on infectious disease immunity was kind of reintroduced. It seemed like it'd kind of been on the back burner for a while. And then so a pretty major researcher, Phil Calder, in the nutrition and omega-3 area, just kind of compiled the nutrient intake recommendations that have evidence that affect the immune system. And so we went through kind of the big ones, and no surprises here. Vitamins in general and trace elements are all part of the systems that help keep basically neutralizing reactive oxygen species, and all these different vitamins and trace elements are essential for certain enzymes to be fully functional. So being deficient in any of these can really start, the immune system can really start to fail in certain ways. So we're not going to go into every single vitamin, but it is important to understand beyond omega-3 and vitamin D, there are a lot of other parts of nutrition that have been studied with regards to immunity. Vitamin C is also probably the most famous one, where there is some evidence that higher doses of vitamin C can reduce the severity and the length of an upper respiratory tract infection. Whether it can't fully block getting sick ever, which is sometimes where people go in their mind, but it can sometimes help with the duration of disease. Then there's vitamin D, which he mentioned at an intake of 2,000 IU a day, has evidence that it can reduce the risk of getting an upper respiratory tract infection. So actual prevention of getting sick instead of just shortening the time you're sick. Zinc, another mineral that has a zinc and vitamin C kind of are connected in some ways, but they both can kind of do a similar thing. And omega-3s were included on this list, and omega-3s are not part of the classic vitamins and minerals list. They're essential fatty acids, so somewhat they're part of the omega-3 family. And so omega-3s affect the immune system on the inflammation side and helping to resolve it. And so that's a really different angle for immunity. And so their recommended daily intake, basically to avoid deficiency, was recommended at 250 milligrams a day of EP and DHA. So let's go into vitamin D. Real briefly, vitamin D, also known as calciferol, is a fat-soluble vitamin. It's present naturally in only a few foods, fatty fish being the primary foods. Some are dairy foods are mostly fortified with vitamin D. And there's plenty of dietary supplements. So that's how we get it in foods. Vitamin D promotes calcium absorption. It maintains adequate calcium and phosphate concentrations so that bone mineralization can occur properly, and it also prevents hypocalcemic tetany, so muscle spasms. It really is helping that whole system to be in proper for every different type of tissue. The sources are we endogenously make vitamin D when the skin is exposed to UV light. So that's where we can really be very efficient in making a lot of vitamin D, but there's a lot of variables that affect our ability to do so. And then the exogenous sources are, of course, the food sources, and it can either be ergocalciferol, which is going to be from a plant source, and cholecalciferol, which is from animal. Both of those can come together and be metabolized to make active vitamin D. Deficiency symptoms, vitamin D is kind of a classic nutrient, so there are classic deficiency symptoms: rickets in children and osteomalacia or porosis in adults, both basically around not having bones that are formed properly. Rickets and osteomalacia are kind of soft bone issues. And then toxicity for vitamin D is around having too much calcium in the blood and what that does across the system. So vitamin D, calcium, very tightly connected in all these ways. But when we talk about vitamin D and immune function, it is a little bit different from the classic idea of vitamin D in bone. But there's a lot of evidence around vitamin D and immune function, especially in the lungs. So this is a really nice diagram showing how sunlight hitting the skin, we get 7-dehydrocholesterol, and that is converted to cholecalciferol, or you take it in through foods, and you can take it in through either of those plant or animal forms. In the liver, then you get 25 vitamin D, which is what we typically measure in the blood. And then there's more hydroxylations to get what we call the active form. And that's what's really, we think, acting on all the cells. But the 125 does not circulate as widely, and 25 is what is typically measured in the blood, like I said. So here we see there is an effect of vitamin D on basically the integrity of your lungs membranes. Maintaining the tight and gap functions is super important for the lungs to maintain their health. It's similar to the gut. And so there's also, as it shores up that physical barrier in the lungs, it also is modulating the downstream effects of inflammation, all the signaling, the inflammatory markers, what happens when the body knows it's being attacked and it starts to release all of its ability to defend itself. That's actually what makes us feel sick. But the vitamin D actually can kind of dampen those responses, so maybe it's not as intense. So clinical impact, putting these kind of mechanisms together, is there is a reduction in just overall inflammation, acute respiratory distress syndrome, and pneumonia infection. All of those can be affected by having appropriate vitamin D levels and supplementation. So as we discussed, vitamin D is kind of an interesting vitamin because we can make it from the sun as well as eat it, but we can't always make it from the sun. It depends on the sun and the latitude we're at. And so this is a real interesting graph where you can see you can make enough vitamin D to hit kind of the RDA in a really short amount of time if you are in kind of close to the equator type of latitudes, and especially during the summer months in the northern hemisphere and the winter months in the southern hemisphere. Whenever you're kind of in that summer season, you'll be able to make vitamin D very effectively, really only needing 10 minutes of exposure if you have light skin and 45 minutes if you have dark skin. And then the orange, it's a little bit more time that you'd need to be exposed to the sun to make enough vitamin D, and yellow's even less. And the clear circles are when there's not enough sunshine at all to make adequate amounts of vitamin D. And the only areas where people actually are living, because this is all over the ocean, are a good chunk of the US and Canada, and then Russia, Japan, and East Asia over here. So these major population centers are potentially at higher risk of having vitamin D deficiency. Consuming vitamin D, here we have the main sources, and it's mostly fatty fish for the cholecalciferol, which is really convenient because that's what we need for omega-3s too. And cod liver oil kind of famously has omega-3 and D in it. Egg yolk, and then the mushrooms are where the ergocalciferol comes in, and those are technically UV exposed mushrooms, which is also interesting. And then mostly we have dairy products and orange juice that are our fortified vitamin D sources. So some research on immunity and vitamin D. This is from N. Haynes, about 18,000 people, finding that people with higher plasma vitamin D levels had fewer upper respiratory tract infections over the year. And N. Haynes is great data. It's a representative sample, pretty meticulously. It's meticulously, the data is collected in a way that's trustworthy. So we have winter, spring, summer, fall. This is the US, so it's northern hemisphere. And in every season, you can see there's a stepwise risk for having a recent upper respiratory tract infection. Those less than 10 nanograms per mil are all basically always at the highest, have the highest amount of those respiratory infections. So this is kind of our first sign that vitamin D, circulating vitamin D, does have a relationship with whether or not people are getting respiratory tract infections. Then we look, this is a meta-analysis looking at supplementation studies, and the overall finding is that supplementation with vitamin D does protect against at least one acute respiratory tract infection kind of per season. So this is a meta-analysis of 25 studies, pretty high quality studies. They're all double-blind, placebo-controlled, 11,000 people included. The overall finding was that the risk of acute respiratory tract infection was reduced by 12% in the groups that were supplemented with vitamin D versus those who didn't. And then they were able to see with not all of the studies had blood levels. So within the studies that had blood levels measured, these protective effects were much stronger in people who had a baseline of less than 12 nanograms per mil. Actually 70% reduction in this risk for respiratory tract infections. And those with levels greater than 12 had only a 25% reduction in risk. So again, baseline, it's really important to know what the blood levels are. And so vitamin D and COVID, during the height of the COVID pandemic, many studies and news stories were always talking about vitamin D. And there are studies showing that lower vitamin D status was related to greater odds of having a severe COVID outcome. Another thing to note is that lower vitamin D status was also strongly linked to a lot of other factors that increased risk for severe COVID. So it's kind of confusing what's the direct relationship? Is it vitamin D to COVID, or is it all of these other things that you're just generally more at risk to have a severe infection, and vitamin D is just going along for the ride? But regardless, being older, obese, male, having hypertension, living in the northern climates, and coagulopathy, those are all things related to low vitamin D status and risk for severe COVID. And as of 2021, there were 16 randomized controlled trials to supplement vitamin D and then look at COVID outcomes that were registered. And I was not able to see that many of them had been published on yet. But there is some out there. So this was a meta-analysis on some of this published vitamin D studies for COVID. And they did find that the supplementation of vitamin D during COVID reduced risk for severe outcomes, which was an ICU admission or mortality. So this forest plot shows that it favors vitamin D across all of these studies. So it's about 2,900 COVID patients. So that's some really nice data. That's pretty strong and robust. So that together with some of the older studies that showed that respiratory tract infections affecting the lungs are also reduced by vitamin D does kind of come together and show the picture that vitamin D is clinically helpful, especially for these kinds of illnesses. So how do we use this data clinically? Indications for vitamin D testing, they're mostly around blood health or bone health because of the classic deficiency symptoms. There are medications that are known to interfere with vitamin D that would make you want to test for levels. Malabsorption makes sense. People aren't absorbing fat very well or anything, then their vitamin D levels could be low. Hyperparathyroidism and hepatic failure. So all of these, any of these conditions, we would recommend a vitamin D test. And then there's recommended screenings, and these are just folks that are just at higher risk because of potentially the darkness of the skin, the amount of melanin in the skin affecting the ability to more efficiently make vitamin D. So African American and Hispanic children and adults. Pregnant and lactating women require more vitamin D because of the growing fetus. And older adults with potential fall risk could also benefit potentially from some extra vitamin D, and then children and adults with obesity. Here's where we get confusing because vitamin D actually doesn't have, there's kind of two competing recommendation narratives around blood levels, and this knocks down to recommended intakes. So the IOM mostly focused on the deficiency state and bone health. That's where they're looking at all their data. They're saying that 12 nanogram per mil, that's considered deficiency, higher risk of rickets and osteomalacia. And also we saw with the respiratory and tract infection data, that marker is really where you see a clear difference where someone really benefits from supplementation is if they have low levels to begin with. And then they kind of have some other categories. 12 to 20 is inadequate, greater than 20 is adequate, and they don't recommend having greater than 50 nanogram per mil, but they don't have any optimal level report denoted. Like I said, bone focused. So the Endocrine Society has looked at vitamin D from a different angle. They're looking at more of the studies on chronic diseases, cancer, cardiovascular disease, even mortality, and looking at blood levels and seeing what would be the optimal level. They recommend 40 to 60 nanogram per mil is the optimal, and then less than 20 is deficient. And so that's, shifted up from where the recommendations are for the IOM. Oops. Oh, I really skipped. Okay. So I do want to note that with the Endocrine Society in the paper, they actually say that the target value of 40 is set even a little higher than maybe where the data is. The true value of 30 nanogram per mil is actually where a lot of the data shows where the risk for all of these different outcomes that's kind of where it starts to plateau, and you don't get a whole lot of extra benefit going beyond 30. However, they made a note about the method used to analyze vitamin D. It's not standardized. And so to kind of guarantee that anyone getting tested from any lab is going to have a true value of greater than 30, they're going to recommend 40 nanogram per mil. And so I'm going to go into this a little bit more later, but this is an important thing to note when it comes to vitamin D testing, is the lack of standardization and knowing where you're getting your data. So here at OmegaQuant, we actually selected 30 to 50 nanogram per mil for our optimal range based on many of these prospective cohort studies showing that 30 nanogram per mil being an appropriate target, and because we know what analysis method we're using and that it's appropriate for that lower target. Something I really want to make sure is clear is that there are two common units used for plasma vitamin D all over the literature, all over everything. So it's really confusing, and it's so important to know what units you're talking about when you're looking at plasma vitamin D levels. So in the US, we typically use nanogram per mil, and that's what's usually reported out by the labs. But a lot of the literature and really kind of the rest of the world uses nanomole per liter. So they're two concentrations. They're the same, essentially. I mean, they're both accurate, but they're two totally different scales. And so if you're saying, I need to get to 50, which 50 is it? If it's 50 for nanomole, that's kind of the normal recommendation, getting above 20 for the IOM. If you're talking about 50 nanogram per mil, that's not really anywhere in the recommendation. I mean, that's within the Endocrine Society, but theirs is 40 to 60. So it's just really important to know which one you're targeting, because that is going to vastly affect how much you recommend for supplementation, or how you see the patient's overall picture. So for the OmegaQuant, we are 30 nanogram per mil, which is 75 nanomole per liter. That's where our target level is. So because of these two kind of competing narratives, there are competing narratives for dosing. The IOM recommendations, the RDAs, are between 6 and 800 IU per day. This is again to make sure that 98% of the population is not deficient. It's kind of the goal of the RDA. Their upper limit is 4,000 IU a day. So there's not recommending to go above that from the IOM. The Endocrine Society has higher recommendations. So they recommend usually between 600 and 2,000 IU a day. And that's kind of, again, to the baseline for them. And their upper limits reach 10,000 IU for adults, 4,000 for kids and teenagers. And they argue that the safety data at 10,000 IU is very good. So again, these kind of back and forth recommendations. For us, if we're targeting 30 nanogram per mil, for most people, this should be achievable around the 4,000 IU a day mark. This, of course, needs to be individualized, but targeting, being between 2,000 and 4,000 IU should be able to get up into that optimal range. But we do have an Omega Quant calculator for vitamin D, the equations from this scientific paper here. There's limitations, probably because the paper, the participants they didn't have anyone over 275 pounds in it. So it's not recommended to use with people higher than that weight. The target range is limited from 30 to 50 nanogram per mil, and it does not recommend more than 4,000 IU a day. We are staying within the IOM recommendations. You can toggle the units between nanogram and nanomole, so know what you're doing. And if you want a more expansive calculator where you can go higher for your targets, higher for the weight, and the recommendations will go higher, you can go to the Grassroots Health website, and they have another nice calculator there. So what I mentioned about the labs and having different systematic effects on plasma vitamin D levels. So there are a lot of different machines that are used to measure vitamin D status. One, kind of the gold standard machine is using LCMS, liquid chromatography mass spectroscopy. That is, that's how they kind of determine the true value. So most labs, we're included in this. We do something called proficiency testing. So this is when a company or an organization sends out basically like 5 samples where they know what the true value is. They know they sent out a vitamin D plasma that's 5 nanogram per mil, 20, 50, 100. They know the true value, and it's a spread. All these labs analyze those samples. They don't know what they are, send it back in, and then that organization says, this is how close you were to the true value on all of those different samples. So the true value on this graph is if you're right on this 0 line. So this is the percent difference from the true value. And as you can see, each of these is one of the 5 samples. So there's kind of a lot of variability around each, around the line for each of the different kinds of samples. It's acceptable to be within 25% above or below this line. 15% is usually kind of our goal. So this blocked one, number 10, this is from labs that use the LCMS method. So they're coming in with values that are a lot tighter to what the quote true line is. But you can see some of these different types of machines are getting a lot more variability, and some of them are consistently low, some are systemically high. And this is something when you're using, some of them are using basically what an ELISA machine, and ELISA is it's less specific than the LC, and it can potentially be impacted by other samples. We tend to see that it runs higher than maybe the LCMS, which is one reason that since we know we're using the LCMS machine, our values are not systematically higher. However, the moral of the story here is, lab testing is, as for vitamin D specifically, is known to have a lot of variability. It's one of the reasons that the Endocrine Society actually changed their recommendation. So this is a known factor. You can still use lab testing, but it's really important to use the same lab and the same test from the same lab. I know at either Quest or LabCorp, you can do immuno assay, the ELISA, or you can request the LCMS, and there's going to be a price difference. Use the same test from the same lab if you're testing a person more than one time, or just looking at blood values across your different patients. Factors affecting plasma vitamin D in a healthy population. We've kind of talked about this, but darker skin, those groups definitely don't make as much vitamin D from the sun. And those who might be at extra risk of having low levels dark skin groups who are living in northern latitudes, although there is no evidence that African Americans in the US, for example, have higher rates of osteoporosis. So that vitamin D level might not be directly linking to risk for osteoporosis for them. Adiposity lowers the plasma vitamin D levels. And being indoors quite a bit also would obviously reduce exposure to sunlight and lower levels. Questionable factors that may be affecting, you might expect to see lower levels in people who use sunscreen a lot, but it's really inconsistent. We usually see across the board in northern hemispheres higher vitamin D levels in the summer, even with sunscreen use. And living at upper latitudes, although it makes sense with the different ability for us to make vitamin D from the sun changing, they really don't see a strong correlation between latitude and vitamin D levels because, of course, there are other things besides the sun that affect that level. And some emerging factors are interactions with drugs, like we mentioned, oral contraceptive use and premature birth, all potentially affecting or being affected by vitamin D levels. So let's talk about a clinical example. This is a 45-year-old female, 25 BMI. She's Caucasian, living in southern US of Northern European ancestry, taking oral contraceptives, has a history of osteoporosis. In the winter, she's at 18 nanogram per mil, and in the summer, she's at 35. So she's getting that sun more so in the summer and then in the winter. So my recommendation would be, if you can, spend more time outside. That's good for a whole lot of things. And having that, the whole sunscreen issue is really important. So some people will have a greater need for sunscreen than others. If you burn instead of tan, definitely don't have as much leeway to have exposure. So up to 20 minutes of direct sun, midday sun should give you a whole good amount of vitamin D. But if that's going to burn you, then that's not recommended. So use sunscreen based on your skin type to avoid burns. And in the winter, it wouldn't be a bad idea to supplement with 2000 IU of vitamin D over those winter months, and always increase fatty fish intake. That's going to be good for a whole host of nutrients. Here's example 2, a 32-year-old female, BMI 33. She's African-American, living in the Northwest. So north and very cloudy, not on oral contraceptives, and does not have a history of osteoporosis. Her level is 12 nanogram per mil, so right on that deficiency line. So here we would recommend vitamin D supplementation off the bat, 4,000 IU for 3 months, and then retesting to see if you need to go higher or if that's a good dose for her, and also increasing fatty fish intake. Third example, here's a 20-year-old male. He's an athlete, an indoor collegiate athlete, so spending a lot of time indoors. African-American, living in the Southeast US with a BMI of 24. And he is experiencing muscle aches, depression, and fatigue, and his vitamin D level was measured at 10 nanogram per mil. So he is fully in that deficiency level. Muscle aches, depression, fatigue could be related to his vitamin D level. Also, they're somewhat vague symptoms, so they can also be related to just being in a sport. But regardless, his level is quite low. So if you have access to a physician, if he's a collegiate athlete, maybe they have a team physician that he could go get, he could go talk to and potentially get a prescription dose, which is a bolus of 50,000 a week. But if you don't have access to the physician in the near term, you could recommend like a 5,000 IU a day. I know most of the supplements come in like 2 and 5 and 10,000 IU. So you could get them started on a higher dose and then retest more quickly in 6 weeks to determine if you need more of a dose and if you can increase fatty fish intake. Another example is an older gentleman, 72 years old, BMI of 35, Indian American, living in the Northeast US. And he has an indoor office job, some depression, especially in the winter months, and his vitamin D level is about 17. So this is another person, because of BMI and indoor office job, recommend the 4,000 IU a day for 3 months and retest if a higher dose is needed. And also try to incorporate more fatty fish into the diet. So those are a couple of examples of where you can where you want to go all the way to that 4,000, 5,000 IU limit right away versus trying to have someone build it up through lifestyle and intake. So let's go to omega-3s and immunity. What are omega-3s? They're a family of fatty acids with a double bond on the third carbon from the omega end of the fatty acid. That double bond makes them essential because the body cannot put a double bond there. We don't have an enzyme for that. The ALA, alpha linoleic acid, is the quote essential one. That's the 18 carbon plant-based omega-3. But the one that we are talking about today, and that's usually being talked about, are the long chain, the 20 and 22 carbon marine derived omega-3 fatty acids, EPA and DHA. And so EPA and DHA are present in seafood and fish naturally, and that's pretty much the only natural source. So we also have dietary supplements, any kind of fish oil, algal oil, krill oil. There's all kinds of things these days. Systemically, omega-3s, EPA, and DHA have been shown to affect kind of all things around blood flow, from blood pressure to endothelial function, cardiovascular disease outcomes, and then also inflammatory pathways. So there's a lot of evidence that they're involved there, and also they lower triglycerides in the blood. So deficiency symptoms for an essential fatty acid are typically around skin health, but then for omega-3 specifically, perhaps elevated triglycerides, excessive inflammation, which is fairly vague, and then increased risk for sudden cardiac death and preterm birth. Toxicity symptoms are decreased ability to clot blood or depressed immune response. Polyunsaturated fatty acid pathway for both omega-6s and omega-3s, and I'm going to talk about this because we were talking about inflammation, and this is a potential one of the mechanisms for omega-3s. So this is where we have our parent omega-3 and omega-6 fatty acids that we have to eat, and then the body can add carbons and double bonds through various enzyme activity. And it's the same process, whether it starts with an omega-6 or omega-3. And then what we can see here is there's a few where there's these lines coming off. These are enzymes. Enzymes are using these fatty acids to make a whole host of metabolites. And they can be prostaglandins, thromboxanes, resolvins, all kinds of different metabolites that are almost all really potent. A lot of them are inflammation, based around inflammation or blood clotting. And so the arachidonic acid, that's an omega-6, and this is a really important precursor to all of these metabolites. And we tend to call these the pro-inflammatory metabolites. And then the EPA is also used by the same enzymes to make similar metabolites that are either less potently inflammatory or anti-inflammatory, or they actually act in the healing process. And DHA is also involved, can be used by the same enzyme for some of these anti-inflammatory metabolites. So the pro and anti-inflammation timing around these metabolites is really important. They both have a place. They're both important. So I'm kind of generally, the arachidonic acid metabolites are going to be happening earlier in the inflammatory process. So this is a really nice graph that shows what happens when you have an event, or you get a cut and you need to, your inflammatory processes start going. So you have acute inflammation right when that cut happens. This y-axis is kind of inflammatory activity, and down here is time. So within seconds to minutes, we have edema. We have a lot of blood flow to that area to bring the white blood cells, to bring all of the appropriate you have the swelling, you have the pain, you have all of those reactions to that cut. That's what the edema is, but it's for an important purpose, and it happens very quickly. And then, and all of these are really starting right away. So these metabolites are starting a cascade that's really important. And then we have PMN infiltrations. The white blood cells are really getting in here. I think the immediate danger has maybe passed, and it's starting to clot up, and we're starting to deal with the bacteria that's in there. And there's still a lot of active inflammation happening around the side of the cut. And then over minutes to hours and days, then you're going to have you're starting the healing process. And this is where the EPA and DHA metabolites really come into play more. And you have, recruitment of the white blood cells coming in there, and some of these metabolites related from EPA and DHA stick around for hours to days to help clear that area and heal it appropriately, and make sure those inflammatory molecules are knocked down, are not continuing to act, and when it doesn't need to act anymore. So one of the ways omega-3s affect inflammation is that EPA and DHA actually tend to replace arachidonic acid in a cell membrane. So over here we see a cell membrane, and EPA and DHA are within this, the phospholipid bilayer, and arachidonic is there too. And that's kind of where they're stored so that they can be used by enzymes. Will pull them out of the membrane to use them to make these different metabolites. So when we do take EPA and DHA, eat a bunch of fish, we see that there's kind of a direct replacement of arachidonic acid and other longer chain omega-6s with these longer chain omega-3s. And so they don't change out with the saturates or the monos. The polyunsaturated fatty acids are maintaining kind of the same amount overall, but switching in the EPA and DHA amounts. So if you're lowering the amount of arachidonic acid, increasing the EPA and DHA, the potential of the cell may be more balanced towards having more access to the healing molecules that the EPA and DHA bring on. And this nice graph also shows all the other ways that EPA and DHA and arachidonic acid are used within the cell, relating to inflammation, relating to activating nuclear receptors, changing gene expression, changing the signaling cascades for those inflammatory processes, changing how the whole membrane acts, how all of these proteins and ion channels, everything can be affected by the structure and the composition of the actual fatty acids in the membrane. And then outside of the cell wall, those can also access these fatty acids for the white blood cells and the platelets. And those have those same COX and LOX enzymes to be able to make those metabolites. So a lot is happening, and it all kind of comes from this membrane level. And another cool thing that was really kind of discovered during COVID is that having omega-3s in the membrane can actually reduce the ability of the virus to bind to the host cell around the spike protein. And so it could reduce the ability of the virus to replicate if it can't access the host cell. So that's a whole different area beyond the immune response, which we've kind of already talked about. So the omega-3s can work in two ways. So if we look at COVID, there have been several studies, kind of like for vitamin D, around omega-3s in COVID. This was one from the UK Biobank, which is a large repository of health information that has been really useful for research. They found that people who reported supplementing omega-3s were less likely to have severe COVID outcomes. And so a fish oil user here has significantly less risk of having those severe outcomes, about 20% less risk compared to a non-fish oil user. And mortality was also reduced. But that's self-reported data. We would kind of assume that the fish oil users have at least a little bit higher blood levels of omega-3s. This is a cool study that is not published yet. It's by Dr. Harris at the Fatty Acid Research Institute. They were actually wanted a better marker of omega-3s than just self-report. So same database, UK Biobank, but we're able to look at actual blood levels, specifically DHA, and found similar patterns where the people who had the lowest levels of DHA in their blood had the highest percent that tested positive for COVID in the first place, the highest hospitalization rates, and the highest deaths. And this pattern decreased as you went to the highest people with the higher levels of omega-3s in their blood. So this is on average about an 8% DHA level, which might be a 9 or 10 omega-3 index. And this is about a 3.5 DHA level, which might be a 4% omega-3 index. And we do have a funny little bump up here for the death rates. And this could be because the numbers start to get very small here, making that pattern not be as consistent as the other two. So blood levels, intake, and testing. Let's talk about clinically how to use this. Omega-3s, like I said, they are not, especially EPA and DHA, they are not recognized as important as other vitamins and minerals, and even like the essential fatty acids by the IOM. It doesn't have an RDA. So we don't have the same kind of information and recommendations for omega-3s as we do for vitamin D. The dietary guidelines do recommend 2 servings of fish for basically everyone per week, and that's great. And then other various entities can recommend usually between 250 and 500 milligram a day for kind of your baseline EPA and DHA intake. And there are no recommendations on blood levels. Blood levels, again, this is another area of a lack of standardization. So an omega quant, that's actually kind of why we exist, is because there really wasn't a good way to measure omega-3s in the blood in a way that was made sense. So we recommend an omega-3 index range of 8 to 12%, which I will define soon, for optimal health. And people with a less than 4% omega-3 index is considered an undesirable level. We don't really use the word deficiency because we aren't kind of an official vitamin. And a combination of supplementation and fish intake is usually needed to reach optimum status. So let's get into it. So I mentioned the omega-3 index, and we've already been talking about that membrane. So the omega-3 index is actually a measure of the fatty acids in a red blood cell membrane specifically. And we take the total amount of fatty acids in the membrane, and then we take the EPA and DHA content and divide it over the total, so we get a percentage. So the omega-3 index is a measure of the EPA and DHA in the red blood cell membrane expressed as a total percent of total fatty acids. And so this example, this would be a 6.25% omega-3 index here. The omega-3 index desirable level of 8% was really determined based on sudden cardiac death research, finding people with about 8% and higher had a lower risk of sudden cardiac death versus people with 4%. The omega-3 index is also really tightly correlated to intake. Our bodies don't do a great job of making EPA and DHA from those plant-based sources. So fish intake, fish meals per week is here on the x-axis and the omega-3 index on the y. People who didn't report supplementing in the light blue and did report in the dark. This is data from Omega Quant. So these are people, about 3,500 people. And so what we'd like to see is this stepwise increase, more fish intake, higher average omega-3 index blood levels. That makes sense. If you're supplementing, that usually adds about 2 percentage points to the average omega-3 index. But do note what it would take to get to 8% without a supplementation would be at least fish intake of more than 3 times a week. It's more like we see in a natural population, it's people who eat fish every day. It's the Japanese type of diet. Some areas in Africa that we've studied that live near a lake and they have a fish every day. Those folks end up at about an 8% without supplementation. If you're not eating like that, you likely will need a supplement to get there. Note if you're eating fish once or twice a week, you could expect to be between 5 and 6% pretty regularly. And that's if you're eating fish that has good omega-3 content. Speaking of which, not all fish have omega-3s. And really, kind of unfortunately, the most potent omega-3 rich fish are kind of fish that they eat in Scandinavia and we don't necessarily want to eat here. So like herring and sardines and mackerel are really great sources, but they sometimes are harder to learn how to eat. So we do have salmon, which is really probably the most popular source here in the US, as well as tuna. So this is a list from our report that lists the these different fish types and then gives EPA and DHA content per 3-ounce serving. If someone's using fish to increase their omega-3 index, it usually will take longer than using supplementation. And then there are those 5 main fish that should be avoided, especially for pregnant women. They're usually larger, and those should be avoided for mercury toxicity levels. But most of these other fish are really, they are very low in levels of these toxins, and the risk is not even close to what the benefits are. So the smash fish, sardines, mackerel, anchovies, salmon, and herring are all kind of potent omega-3 fish. Just considerations around fish oil supplements. Dose, calculating the EPA and DHA milligrams per serving per the serving size, how many capsules is absolutely essential to do. That's if you're using our calculators, you have to find out what the actual EPA and DHA amount is on not the total amount of fish oil. There are different forms of omega-3s. So there's a triglyceride form, which is kind of more natural. Triglyceride and phospholipid are more natural forms, but ethyl esters allow for omega-3s to be concentrated a lot more cheaply. But there is some evidence that the ethyl esters can not be absorbed as well as the triglycerides. And so that's something to note. If you have someone and you're testing them and they don't seem to be changing, that could be the culprit. Also, taking supplements with a fat-containing meal is also a great recommendation for best absorption. And making sure that whatever pill is selected, supplement, the consistency is really the most important thing. So if the pill's too big, if it's liquid or there's all kinds of options these days. So make sure you can provide a lot of different options and see what would make people be able to stick to it for longer. This is just a quick case study that came to us. This is a husband and wife, and they tested before they started supplementing. They both were about 5%, and they were eating fish about twice a week. Lila, they started to take kind of a healthcare provider brand at 1,400 milligrams of an ethyl ester, and the wife did not change over 6 months of supplementation, while the husband went up to about 8%. Then they bumped their dose because this was not a happy moment when she found out she hadn't increased her levels, and then tested again in 3 months and found she continued to not change, and he continued to increase. So that's when I talked to her, and we found out that she was taking her pill on an empty stomach in the morning, and he was taking it at night when he was not fasting. And so that one difference can make all the difference for some people. So once we got her on a triglyceride base and she started to take it at a different time, she jumped up to almost 8% on only 1,200 milligram dose. The amount of EPA and DHA consumed is the most important factor for the omega-3 index. This is from a paper that we wrote, but we estimate that for someone to go from 4 to 8% takes about 1,400 milligrams. If it's a triglyceride form, it takes about 2,200 milligrams if it's an ethyl ester form. So these two lines are for the two different forms because it makes that big of a difference. And so just noting if you have an ethyl ester, just make sure you're going to be probably taking a little bit higher dose to get the same response. Like I mentioned with the vitamin D testing, the omega-3 status testing is not standardized either. It's even less standardized than the vitamin D. Because it's much, much less popular. So this is just a quick showing that the way we analyze fatty acids, we provided a sample to 5 different labs. And we got 10%, and you can see different labs got all these different percentages. Again, for this, in this case, there's no right answer at this point. There's no, it's becoming better. CDC is starting to have people be able to not officially proficiency test, but test omega-3 levels against some of their samples. But differences in sample type, differences are also based on just what fatty acids you're measuring and the methodology. And another big thing that we put an antioxidant blend on our cards. If you're doing the finger prick, that's absolutely essential. If that is not there, the fatty acids will degrade and you'll get a low omega-3 index. Depends on if the lab is measuring serum or red blood cells, it will be a totally different number. And then what's being reported, is it EPA and DHA? Is it a concentration? Is it percent composition? All of these things have to be noted to understand what scale you're going to be on. All right, so clinical examples. We have a 67-year-old male African-American living in the Southwest US, BMI of 27, has achy joints, is on a statin, but he's active, he's a vegetarian, and his omega-3 index is 3.5%. So that's pretty low. I'm going to recommend trying to do 2,000 to 3,000 milligrams a day of EPA and DHA. If he's open to it, I would try to go with the regular fish oil because it would be much less expensive. But if he wanted to stick to vegetarian or a vegan option, algal supplements with only DHA would be okay. You might have to lower the dose if it becomes too expensive, or you have to take too many pills. The algals aren't nearly as concentrated as the other ones at that price point. He can take in more ALA if he'd like, but that's not going to be the main thing changing the omega-3 index. And sometimes vegetarians are open to adding fish into their diets. So you could have that conversation as well, and then retest in 3 months to see where you're at. It's a 45-year-old woman, Asian American, living in the upper Midwest. She's had a hysterectomy, BMI of 33. She frequently gets colds and viruses in the winter. She has allergies. She is not a fish eater. She likes shrimp and tilapia, but does not eat salmon or tuna or any of the others. So she's at a 4.3%. So I'd recommend a 1,500 to 2,000 milligram a day of EPA and DHA, trying to eat more fatty fish, salmon, and the others on that list. And then retesting in 3 months for her. And then we'll see if any of the other frequent colds or allergies is also affected by increasing the omega-3 index. And so for the third example, we have a 33-year-old man, a young man, Caucasian, living in the Mountain West, BMI of 24, has skin and eye dryness, but he does eat fish weekly, salmon, shellfish, and sushi. So he's at 6.7%, which is really good without supplementation. Recommendation would be, if he's interested, he could increase his fish intake even more and focus on adding the very high omega-3 fish. He could also add kind of a mid-dose, 500 to 1,000 milligrams a day of EPA and DHA just to get him, top him off. And having that extra supplementation might be the key to improving some eye dryness, especially if in the Mountain West, if you're in the high desert, it's really dry out there. So having that extra supplementation could be really beneficial for that as well. So retest in 3 months. To wrap up, maintaining higher blood levels of omega-3 and vitamin D throughout the winter should provide extra protection from upper respiratory tract infections, severe COVID outcomes, in a variety of mechanisms. The good nutrient status is really important, but it doesn't replace other forms of protection against colds and flu and COVID, vaccine protections, as well as staying home when you're sick. So that's all a part of the prevention. And testing provides insight into the amount of supplementation and lifestyle changes that are needed that would most benefit your patients. Can't manage what you can't measure. And that's all I have for today.
Excellent. Dr. Harris-Jackson, thank you so much. We have a lot of questions that have come through. Let me go ahead and go to the beginning. and see what we can get through at this time. So Steve wants to know, would measuring the active form of 125 or both forms be better? Is there research that looks at the effects of higher vitamin D levels, 30 to 50, 50 to 80, 80 to 100, et cetera?
Yeah, so I have not seen, I've seen in the prospective cohort studies, they have groups that are at the higher ranges. Those numbers usually start to get very small. There's a lot less people up there. But I haven't seen that like RCT data where they're getting people up to those levels and comparing them across against someone who's at 30 and seeing those differences. And this is something that we see in a lot of nutrients, where most of the action clinically is happening at the very low levels. That's the deficiency. It's the most obvious thing. But when you start to look at the optimal levels, your outcomes are not as obvious, maybe not statistically significant. And that might just be a failure of the research. But from what I've seen, when we're looking at mortality and cardiovascular disease, it looks like there's a big risk reduction when you go from 12 to 30, and then it kind of plateaus from 30 to 50 to 80. And then sometimes it starts to come back up a little higher risk as you get higher up. So I haven't seen really compelling evidence that being at 50 is that much better than being at 30. But I am not like that's just from my experience and from what I've seen in the literature.
Okay. Is there extra benefit to have omega-3 index closer to 12% versus 8%?
Similar kind of idea where you kind of get diminishing returns the higher you go. There is some data from Japan where they're starting off at an omega-3 index of 8 and going up to 12. And they see there's some benefit in the cardiovascular outcomes. But again, it's kind of an issue of we don't have enough data. What are the outcomes we're looking at? Most of the strongest data we see is going from the 4% to the 8%. And so that's kind of where you get your best bang for your buck at 8%. But we don't see any big toxicity, like there's no real issues at 12% for most people. And we even see people going in the 15, 16% now. And we don't see any major issues with it. It just might not be getting that much extra benefit being that high.
Could you talk a bit about vitamin D and omega-3 interactions with other vitamins and minerals, specifically the best time to take these two supplements in terms of food or other supplementation consumption? A lot of information.
I think for both of them, they're both fat-based, and so taking them when you're eating and when you're having fat, and that whole process is when that process is activated by a full meal, I think you're going to have better absorption across the board. I find it really interesting that fatty fish that is present at the northern latitudes is a great source of omega-3 and vitamin D. So it's kind of this really nice package and a lot of other nutrients. And so, yeah, I mean, that's kind of why the food package is so great of fish. But if you're going to do it by supplementation, you kind of want to mimic that whole meal process.
In relationship to omega-3 status, can you reach those levels with just supplementation if you have a limited fish supply in your area?
Absolutely. It's pretty easy to reach it with just supplementation. Yeah, you just hit that 1,500 to 2,000 to 3,000. I mean, there's individual variation for sure. We've definitely seen people who need to be at 3,000 to maintain 8%. But it's a lot of people are meeting it through just supplementation.
Do vegans and vegetarians who eat a low or lower fat diet need less EPA and DHA to reach an optimal omega-3 index because their overall fat intake is less?
That's a good question and an area that needs to be studied further, for sure. We've just had kind of anecdotal discussions with some vegetarians where some of them have been able to kind of manipulate their whole diet and reach higher levels of an omega-3 index at a lower total dose. But we do see that on average, vegetarians and vegans had about a 3.5 to 4% omega-3 index in the study we did with them. And it does take like the dosing from what we can tell is the same. Like you would still need a 1 to 2 grams a day to get up to that 8%. Whether or not vegans need to be at the higher percentages like other people, because not all vegetarians, but some they're already usually doing a lot of other health. They have better health metrics than kind of the average person. So if the omega-3s are kind of combating some of those things, maybe your levels don't need to be as high. The other reason I'm kind of hesitant to say that vegans need to be at 8% is because the process of getting there could be really expensive and a lot of pills, because the algal pills are usually a smaller dose compared to fish oil. But there's it's a small population, so we don't have a whole lot of data on them specifically.
That was the next question, actually, is, or if we look at like an algae oil supplement, are they per milligram equivalent to fish derived? So do they, I guess, provide the same? And I think you just answered that.
Yep.
Typically lower. Okay.
Well, they bump the level, they respond in the blood just like regular fish oil does, especially if it's DHA. So DHA is actually better at raising the omega-3 index than pure EPA. So that's a benefit, but usually the dosing in the capsules is, to me, kind of the limiting factor, where they're just a lot more expensive per gram or milligram of omega-3 than a fish oil based.
So someone's recommending, since we have a guide for triglyceride based, and I think it's actually on our dosage guideline, because they're asking, we need a guide for algae supplementation since I have a client with FISA. Yeah, so it's actually on that. So I'll have my email address, and when I email everyone the replay, and for those of you that are dietitians that are going to get CEUs, if you would like a copy of our PDF of our dose guideline, that'll help with knowing what to do from a dosage standpoint on supplementation. Mm-hmm. Interested in your opinion on the meta omega-3 supplementation increased the risk of AFib mm-hmm. with an increased risk of observed at doses of greater than 1 gram per day. Any news?
Yeah, that's something that we are watching and looking at, and we definitely, there's going to be a paper coming out. I think it's not out yet, from the FARI group, the Fatty Acid Research Institute, and we tend to look at blood levels over time. So what's the blood level 10 years ago, and then did people have more or less heart attacks? And when we look at from that perspective, blood levels are predictive of, basically better cardiovascular disease across the board. When you're looking at supplementation studies, those there seems to be about a 10% increased risk in AFib on the omega-3 arms. And that's something that we need to be cognizant of. I would say most of those studies are using, a lot of them are using a 4 gram dose, the pharmaceutical ones. A lot of them are in people who already, it's like secondary prevention, or they already have a lot of risk factors for cardiovascular disease. So it's not a prevention type of population, it's a treatment. And so to me, using omega-3s as prevention, having higher levels across the, before you start to have these events, is how you actually reduce your risk. But using it as a treatment, you're going at much higher doses. There's already on a bunch of other medications typically, so all the systems are not as healthy as they would be in someone who's using omega-3s to prevent. So, long story short, omega-3s to prevent have a very safe profile. Omega-3s to treat in a high-risk cardiovascular disease population, we just have to weigh the pros and cons a little bit more.
This question,
Go
ahead. Sorry.
Go ahead. No.
This attendee says, can you talk a little bit more about the AA to EPA ratio? Mine is 48.3 to 1.
So we minus 40. I could just talk about the ratio in general. So the AA EPA ratio, arachidonic acid is much higher in the membrane than EPA in general. So that's first. And in the red blood cell membrane. And so that's kind of looking at the potential of the membrane with the different metabolites that come from them. When you take omega-3s, when you increase your omega-3 index, you almost always automatically balance out the AA-EPA ratio. partially because it increases the EPA and partially because it decreases the arachidonics. So you get both happening because really EPA levels are really low. So any change in that kind of dramatically changes that ratio just because of the math of it. So that ratio swings a lot faster than maybe the omega-6 to omega-3 ratio. But the main focus is the omega-3 index is the primary focus of that, and not arachidonic acid is very difficult to change with any kind of dietary habit. And you don't, the only one that really is consistent is increasing the omega-3s.
Excellent. Just a couple more questions. Sam and I put a link to our calculator. So if you see the chat, you'll see a link that will go to our website. You can use our omega-3 index calculator that will help you understand based on the dose or based on the score of an individual. You can look at the dose and type of omega-3, because Sam's question is there a difference between krill and triglyceride-based omega-3 dosing?
Yes, we didn't have enough data on krill to include it in the calculator. So that's the reason we don't. So krill is a phospholipid based, but typically it doesn't perform that much better than triglycerides. We from the data that we've seen, the ethyl esters are without a meal are the ones that show very poor absorption sometimes. So if you're comparing against that, it look like you only have to take half the dose, but you really probably need to be closer to the triglyceride level of dosing for krill to reach those same levels.
Question about the 6-to-3 ratio. If you studied the omega 6-to-3, there seems to be a lot of controversy around avoiding seed oils altogether. Do you just recommend minimizing it as a good advice versus strict avoidance?
Yeah, we don't feel like the seed oils are the issue. We feel like the omega-3s are the issue. And there's in the blood level world, we see linoleic acid, that the main 18 carbon omega-6, it actually has a lot of positive predictions, very similar to omega-3s, predicting higher levels, predicting greater longevity, lower risk for cardiovascular disease. So we try to just not talk about seed oils because they don't really, it's kind of hard to avoid in some ways, or it's very easy just to use olive oil instead of canola oil to cook at a lot of times. So, but we don't think that, we think that's just kind of a distraction at this point. We're mostly focused on the omega-3 side because that's what's really going to change the needle. That's where a lot of most of the data is on that side of it. And again, like changing your omega-3 index does change the omega-6s in your membranes, but you don't necessarily, it's just not as fun of a story, I think, to not have to have a good guy and a bad guy. It's more compelling, but they're both necessary for proper health. It's more obvious that the omega-3s are deficient than the omega-6s are so much higher than they should be to us.
Yeah, the only thing I want to comment, Dr. Harris, is just, personal, I know it's an N of one, but being in New Orleans and Louisiana, there's going to be a lot of things cooked in seed, and what we want to call seed oils and omega-6 rich foods. And when I look at my test, I mean, I've consumed a decent amount of omega-6, and our diet's always going to be pretty omega-6 driven. But when I look at my test and go, all right, I was concerned, will I have a high 6-to-3 ratio? And I was like, wow, it's 2.1 to 1, but my omega-3 index was 13%. How did I get that high? Supplementation, right? I don't eat a lot of fish. So when you mentioned focus on 3, that was really just a one incidence of, wow, that is correct. Focusing on 3 can help with that. All right, last question, because we're coming up on that 1:15 Central Time. When reading the ingredients label on omega-3 supplement bottles, there is always fish oil as the carrier at, like, let's say 1400, then 647 EPA, 253 DHA. How important is the pure EPA DHA versus the fish oil combination?
I always look at the EPA and DHA line separate to calculate and add them together to calculate how much EPA DHA is in the product, because the total fish oil, all the other numbers can mean whatever, but those are the two that we focus on and that we use for, like, if we say you need 250 milligrams of EPA DHA a day, it's those two numbers that matter and nothing else except for the serving size. So always know, is that in 2 pills or 3 pills or 1 pill? So that's so important because that's like the key to understanding how much you're getting. But yeah, I do the math.
Yeah, I see that a lot of fillers, a lot of omega-3s, a lot of omega-9s, omega-6s in a lot of these products. In most cases, the EPA to DHA is so low.
Yeah.
Dr. Harris-Jackson, thank you so much. Thank everyone for attending today's webinar. There will be a replay once the replay is edited and everything is sent out. We had a lot of people come in after we started, so we will get you a copy of that. Be on the lookout for our next webinar coming in February. Once that date is selected and topic is finalized, we will get all of that information sent out to you. So thank you so much for joining today's webinar. We will see you in February. Have a wonderful day.